Okay, thank you very much. I hope you can hear me well. So thank you for this opportunity of sharing with you our experience with the new treatments of hemophilia, in particular hemophilia A, and what the new treatment approach do offer to our patients and our community. So for those of you who might be less familiar with hemophilia, this is the classical treatment of severe hemophilia or patient with hemophilia who have a severe bleeding phenotype. I mean, patients who bleed frequently. So these are the modalities and the ambitions. So the classical treatment has been what we call replacement therapy. By that, we mean that the patient learn to inject themselves regularly with factor VIII concentrate, and they do this on a regular basis. Why do they do this? They do this because they have a major deficiency of factor VIII. Because of that, they bleed, and in order not to bleed, the only way in the past was to inject themselves regularly, and you can see that with this injection, you will get a peak of factor VIII, and then with this factor VIII will be rapidly eliminated from the blood, and then the patient need to re-inject themselves. And the goal of that treatment is ideally to prevent, to treat, to avoid all the bleeds. And as you all know, patients with hemophilia, they mainly bleed in their joints and their muscle, but they can also present with internal bleeds in any part of the body. So clearly, that treatment has multiple limitations. In my country, for decades, that was the only treatment available. But let's be honest, this is a treatment with a major burden for the patient. And let's be realistic too. Many patients are unable to inject themselves regularly because their venous access is not good. Also, by doing this, well, the reality is that this factor VIII is rapidly eliminated from the blood. So yes, you get a good correction just after the injection, but this factor VIII will rapidly be eliminated. And as you can see on the slide, you will have a fluctuant correction. And there is strong evidence showing that this treatment is far from ideal. Yes, it's better than no treatment. It's better than what we call on-demand treatment, so treatment that you receive when you have a bleed. So preventive treatment is better, but we know that this IV treatment does not prevent all the bleeding complications of hemophilia. So we have 7 challenges with hemophilia. The first one is intravenous administration. That is quite problematic, especially in young children, but also in adults. Think, if you had hemophilia yourself, would you be ready to inject yourself 2-3 times a week? Few people are able to do that. The rapid elimination, that has been improved by what we call the new generations factor VIII concentrate with improved pharmacokinetics. So they are cleared from the blood less rapidly. And the third issue, which is a major one, is the immunogenicity. Well, clearly nature and physiology make the treatment of hemophilia really complicated, because if you are able to bring factor VIII in the body, in the veins, there is a like probability that many patients will develop antibodies against this exogenous factor VIII that they do not produce themselves. So these are antibodies. So these are the challenges. The good news is that we now have what we call several non-replacement therapy. So these are treatments that are not based on using factor VIII given intravenously. Many of these treatments can be given by subcut injection. And the most advanced ones, the most widely used ones, are what we call bispecific antibodies. They are given subcut. Gene therapy for hemophilia A is quite challenging. And although there was a lot of hope in the potential of gene therapy to help our hemophilia A patient, well, there has been some disappointment recently. So research is ongoing. And I do not expect gene therapy to be the treatment of choice for hemophilia A patient in the next few years. So this slide shows you a rapid overview of the treatment that we have. We have short-acting factor VIII, we have extend half-life factor VIII. We also have now what we call a ultra-long factor VIII. So this is a factor VIII that can be given once a week, and that will correct coagulation close to the normal range for several days. And then other therapies that are listed on the left, on the right part of the slides, including the factor VIII mimetics. So this is good. We have plenty of treatment options, and I know that in Poland you have some of these treatment options, including the ultra-long factor VIII and the bispecific antibodies. So this bispecific antibody, the name is emicizumab or Hemlibra, commercial name. This agent is quite insightful. That was developed by Japanese colleagues, and I think they need to be acknowledged for what they devised. They realized that factor VIII is helping factor IX to activate factor X, so it helps as a catalyst. But we know that treating with factor VIII is quite problematic, and they had that bright idea to replace factor VIII with a bispecific antibody that would bind on one side on factor IX to the other side of factor X and would do the job. So it's mimicking factor VIII. It's not factor VIII, but it's doing the job. It's given subcut. You can start it very early in life. You can start it at any time of your life, and it's not recognized by antibodies against factor VIII. So this is a very good treatment. It's not longer given IV. It has it does not have a short half-life. It has a long half-life. So patients can be treated every week, every 2 weeks, even every 4 weeks, and there is no immunogenicity. So even if you have antibodies against factor VIII, you can still be treated with that kind of agent. And I think that slide shows you a critical difference between factor VIII that has to be given intravenously with repeat intravenous injection with peaks and troughs. On the right side, you see that with that treatment, emicizumab, Hemlibra, after a loading phase of 4 weeks, you will reach a steady state that will be maintained. If you are treated with that agent, you still have hemophilia, so your hemophilia is not fully corrected, but you have a level of factor VIII equivalent that is above 10, 15, if not 20%. So the disease is totally different, something that is not achievable with a classical treatment. This treatment has been validated in multiple populations, in infants, in newborns, in young adults, in adolescents, and also in older patients without any age limitation. Also in patients who had moderate hemophilia, who had mild hemophilia, patients who underwent surgery. So this is a treatment that was extensively studied in multiple populations. That treatment, so this bispecific antibody, has been evaluated in an extensive clinical trials program, including adults, children, with and without inhibitors, with different treatment modalities. And I don't have time to show you the results, but all these data together show that this treatment is very effective. I wouldn't say that the patients do not longer bleed, but the probability that they will bleed is very, very small. Many patients do achieve zero bleed. I mean, they do not bleed at all during 1 year of treatment. And these are the results that have been seen. The mean ABR, so this is how we calculate the number of bleeds, is below 1, 0.7. So the probability that you will have a single bleed over 1 year is less than 1. Many patients do not bleed at all. And patients who have very damaged joints, bleeding frequently, they target, well, these are called target joints. Many patients show a good resolution of this. And for surgery, and this is also very important, for patients who require surgery, while many of these surgery can be performed with emicizumab, if there are major surgery, they can be performed alone. If it's a major surgery, yes, you will need to add factor VIII to that. So emicizumab is not a monotherapy. You still need factor VIII if you need to fully correct coagulation. So this is important to know. But when you treat a patient on emicizumab for surgery, trust me, these patients will stay in hospital much shorter. He will be discharged very rapidly, and the post-op follow-up should be facilitated. This medication is a very important one. And 2 years ago, with my friends and colleagues, Glenn Pierce, we wrote this document, which was some sort of aspirational document saying that this bispecific antibody should be recognized as an essential medicine. You need to know that a few weeks ago in Geneva, there was a very important meeting of the World Health Organization where they confirmed that, yes, emicizumab is now an essential medicine. So that really emphasizes how important is that medication for all patients with hemophilia, irrespectively of their age and hemophilia severity, at least severe and moderate. So this is really a game changer. That treatment is changing how hemophilia A is managed. Very important to emphasize. So I live in Belgium, in the center of Europe. Well, Belgium did perform quite well recently with a good team. Hope they will be successful next Friday. We'll see what they do. But in my country, which is in the center of Europe, currently we follow a few hundreds of patients with hemophilia. We also interact with plenty of organizations active in hemophilia care. So a few words about Belgium. Nearly 11 million inhabitants, complex countries, as you all know, with multiple languages, communities, approximately 450 patients with severe hemophilia, thousands of carriers, many doctors, 200 hematologists, and approximately 25 hematologists looking after patients with hemophilia. One patient's organization, 6 centers looking after patients with hemophilia. So this is the situation in Belgium. So maybe I can skip this one. The ambitions in hemophilia care today in my country, like in many, many countries today, as a VP medical of WFH, I travel a lot. And please trust me, the new ambitions today are not longer to try to keep factor VIII above 1-2%. We had to do that in the past because we had no other treatment options. Today, we are much more ambitious. We want to keep factor VIII above 10, 15, if not normalized, because this is what the people deserve and need to have a normal life. We want to restore the thrombin generation, and we want to really liberate our patients from the bleed, the pain, the arthropathy. And certainly we want in this community something that has been missing for decades, which is equity, diversity, and inclusion, irrespectively of the hemophilia age and severity. And these are the new ambitions. We want our patients to have no bleeds. We want to minimize the treatment burden. And we want to make sure that our patients have some sort of hemophilia-free mind status. Well, this is totally new. That means that you have hemophilia, you have this dramatic disease, and you wake up in the morning, and with the new treatment, you have this privilege, or, yeah, well, maybe it's a privilege, but I think it's also a right in 2026 to not to think about hemophilia, the bleeds, the treatment, the risk of bleed, the need to be treated. And this is now possible with the new treatment options. And this is this new concept of being hemophilia-free mind. It's an aspiration. I wouldn't say it's possible in every patient, but in a large proportion, this is something that is today achievable. And I think this is a very important slide. For decades, since we only had constant rates of factor VIII, the only ambition was to convert severe into moderate. Today, with the new treatment that we have, we want to convert our patients into mild hemophilia A patient, or ideally normalize their coagulation, because this is important to make sure that our patients have a normal life. You cannot have a normal life if you still have moderate hemophilia, let's be honest. In my country, currently, nearly every patient with severe hemophilia is on prophylaxis. More than 85% of our patients with severe hemophilia are on emicizumab. And why is it like this? Because we realize that emicizumab is currently the only treatment options that makes real prophylaxis, efficient prophylaxis, with the good protection possible throughout life. And for our hemophilia B patient, we don't have such alternative subcut treatment today that mimics factor IX, so many of them are still treated with EHL factor IX intravenously, but that treatment is given once a week or once every 3 weeks. In my center, and these are data 2 years ago, as you can see, among 129 patients, well, 99 were on emicizumab. I'm not saying that the situation will remain like this in the future, because we'll probably have other treatments, other bispecific antibodies, but as you can see on this slide, bispecific antibody is not the treatment of choice for hemophilia A patient. And I need to tell you that this kind of treatment is now started early in life. If today a newborn was diagnosed with severe hemophilia in my hospital, we would start emicizumab today. We would not wait. And emicizumab will be started and it will be continued. It will never be stopped. 2 years ago, I started emicizumab in a patient who was 83 years of age, 83. He is now on emicizumab for 3 years. And he came back to my clinic and he was so grateful. He said, Cedric, thank you. At least over the last 3 years, I haven't had any bleed, something that I've never experienced in my whole life, in spite of many efforts. We also have some women and girls with severe hemophilia or moderate hemophilia. They are also treated with emicizumab and bispecific antibodies. Because today, and I think that should be the reality across all Europe, patients with hemophilia should be treated prophylactically. But prophylaxis does not mean giving a little bit of treatment just to give something preventively. No, we need to achieve a prophylaxis that really corrects the disease. So patients should be able to self-treat, something that is not possible with IV treatment. This treatment should be treated very early, and this is possible with these bispecific antibodies. Home treatment, and what's very important, treating a young boy with hemophilia is an investment. You do this to prevent his future, to make sure that he will have a normal life, physically, mentally, get good education, get engaged in our society. So this is an investment. And that investment should last all the life. So you cannot stop the treatment, the good treatment. If you stop it, the patient will start bleeding and they will have to pay the price for this. And you could lose all the efforts and money that was put into the investing earlier in life. So the treatment, good prophy should be uninterrupted and make sure that treatment is accessible, available, and that the patients are totally adherent and understand the rationale for their treatment. So in Belgium, currently, all these treatments are reimbursed. So the factor VIII concentrate, emicizumab for patients with severe moderate hemophilia, but they need to come to the center to confirm the indication, and that has to be done by a specialist in hemophilia. If you ask me the price of that, I do not know, because there is a fixed envelope that has been decided, and this is now the case in a number of countries. But I think this is a good investment, because by using emicizumab, well, clearly patients are, I don't think it's an expense in my view, it's an investment, because by putting money in that kind of new treatment, you avoid complication, long-term complication, hospitalization, bleeds, and the long-term consequence of hemophilia. Every center is also funded for patients treated prophylactically. This is something I need to do. But at the same time, in my country, there is no specific funding for the hemophilia care center, so it's quite limited. So most of the cost of the treatment today is invested in good treatment. And I think that's quite well organized. So as I said, with a large majority, if not nearly all our patients with hemophilia A currently on prophylaxis with emicizumab. So I think that's the last slide. So just to give you a picture of what are the current ambitions in hemophilia A. If you ask me, are we done? Are we all set? No, I don't think so. Emicizumab is a good treatment, but still, I think there is still plenty of room and space for innovation. Emicizumab does not fully correct coagulation, so we need new generation of these bispecific antibodies. And also we need to continue research into the field of gene therapy and alternative treatments. Certainly treatment that can be given to women and girls with hemophilia, considering their specificity, and also treatment that can really, more or less normalize coagulation so that patients who are treated for their hemophilia, in fact, do not longer have hemophilia, and a treatment that is safe, accessible, and can be continued all the life without contraindication. The World Federation of Hemophilia is a global, worldwide organization. So that means that we do our best to support countries, sometimes with very limited resources. Okay, so is to promote prophylaxis, at least access to prophylaxis for every patient with severe hemophilia on this planet. Okay, so this is because it's impossible to live with hemophilia without prophylaxis in 2026 or 2027. So this is the ambition. The question is, how do you make this prophylaxis possible? How do you want to make it effective? And then, yes, we have different treatment options. And it's clear that the bispecific antibodies are now completely changing the way we treat our patients with hemophilia A. So the next edition of these guidelines should soon be available in the next few months, because the hemophilia treatment landscape changed so much recently. So we will clearly highlight in that document the value of bispecific antibodies, certainly in children, because this treatment has the potential to be started very early in life and prevent intracranial bleed and things like that. But it's clear that the ambition is to continue this treatment throughout life. And I have some difficulties in understanding the situations in Poland. There are plenty of good things in Poland. I've been in Poland a few times. So what's nice is that you have a great hemophilia program. There is investment in hemophilia. You give access to very innovative treatment for children, for young adults. This is fantastic, including the long-acting factor VIII, emicizumab. So this is great. What I do not understand is why you do not continue this after the age of 18. So that does frustrate me a little bit, because at the age of 18, hemophilia is still there. It's still there. And as we discussed previously, if you start this new treatment early in life, so you will prevent all the complication. So you will have young adults who are now 17, 18, not in perfect health, and they might start experiencing the dramatic complication of their disease when they are 18. No, honestly, I cannot understand this. So everything should be put in place to continue that treatment, not to lose on this investment, and make sure that this very good treatment remain available throughout their life. We always say that there is never any reason to stop prophylaxis. There is also no age limit. As I said, prophylaxis with this agent can be started, at any age, even in very old patients. So, if Poland was a very poor country with very, very limited resources, if short-acting factor VIII was the only option, yes, I would accept this. But that would be the first step in helping patients to be on prophy. But in my understanding, the situations in Poland is different. Poland is a well-advanced country. There is a huge Polish community here in my country, in Belgium, and I see many of them going back to Poland just because they say Poland is such an attractive place in 2026. I understand this. Economically, it's a very important country. So please, as VP Medical of the LFH, do everything possible to continue or to allow patients to continue this great treatment throughout their life. I think they deserve it. Our hemophilia community has paid so much in the past with, plenty of problems. And now we have this fantastic treatment. They are not yet ideal. This is important. It's not because, reimburse emicizumab or Altuvio throughout life that we are at the end of the process. Still, there will be new treatment in the future, but I think this is a major transition to help our patients to have access to good treatment. So, and I know there are some disparities across Europe, but if you look in Western Europe, I think all countries are now using emicizumab throughout life without limitation. And even if you go to Eastern Europe and even in Romania, Bulgaria, they are doing everything possible. And I'm not aware of any age restriction. Yes, there might be some population because of local resources. They try to limit access, but there is such a gap now in Poland between people below 18 and people above 18, and that's creating a lot of segregation. And it will be quite hard for the community to accept this kind of segregation. So these are my words, but I understand there are some economic implications related to that. That has a cost, but I have said hemophilia treatment cost. It's not a cost, it's an investment, because if you do not pay for treatment, you will have to pay for the consequences, the disability of people who will not be active in society. They will have to be supported by social benefits, and they will have all the dramatic consequences in their life. And this is what I see in my center. My hemophilia patients on emicizumab, they are economically active. So I'm not saying that they all pay back for their treatment, but they minimize the cost, and it's a good investment. These would be my words. This is also, the reason of my presence today, my contribution to this meeting. So yes, I think this is important. The ambition of the WFH of improving access to this very innovative treatment. Thinking about this again, I think it's a real paradox. Switching a young patient from one of the most innovative treatment to a short-acting plasma-derived factor VIII. This is something we never see. Usually we see in many parts of the world, we see patients being switched from plasma-derived factor VIII short-acting to emicizumab, and there is plenty of literature about this. But having a switch the other way from EMI to short-acting factor VIII IV, this is something totally unusual, especially in a highly developed country. So please do everything possible to avoid that kind of dramatic situation.